USMLE Step 2 CK Hematology Part 4. Today I am going to discuss about sideroblastic anemia and anemia of chronic disease. So first talk about sideroblastic anemia. In sideroblastic anemia, iron will be high, but it cannot be utilized. I'm going to discuss about it. In heme synthesis, impaired in sideroblast anemia, because iron cannot be incorporated into the photoporphyrin. That lead to the cause of the formation of the ring sideroblast. So what is ring sideroblast here, and what is causing to have ring sideroblast? It could be genetics or it could be acquired. Like acquired problem, for example, like isoniazid. Someone have tuberculosis and he is taking the isoniazid. Isoniazid prevent the action of the pyridoxine vitamin B6, which is need to produce porphyrin. We already know it. Alcohol cause it. Alcohol cause the problem to absorption of vitamin B6. Chloramphenicol, lead or zinc poisoning, aminolevulinic acid synthesis deficiency, and a lot of them, like say, cause vitamin B6 deficiency. That is the main cause to have sideroblastic anemia. So what is the sideroblastic anemia? What happened on here? We already know that from the step 1, the blood production go in different stages in the bone marrow, and when in this stage, iron will be trapped in the mitochondria of the nucleated red blood cell. So iron, when trapped in the mitochondria of the nucleated red blood cell, we call it ring sideroblast. And in this case, we cannot produce the hemoglobin properly. We cannot synthesize the hemoglobin. So when this happens, iron is in the mitochondria. We cannot produce the hemoglobin properly. It can lead to microcytic anemia. And sideroblast anemia also can give the macrocytic anemia, and I will talk about when it can give microcytic anemia, when it is macrocytic anemia. And all of these, in the United States, alcohol is the most common cause to give the sideroblastic anemia, and sideroblast in alcohol also suppress the bone marrow, and that can give sideroblastic anemia. So we already know sideroblastic anemia can be acquired or can be genetics. It can give the macrocytic anemia. It can give the microcytic anemia. So when we will have macrocytic anemia, it happens in acquired sideroblast. You are taking medicine and all these things already I mentioned. Then acquired sideroblast will cause the myelodysplastic syndrome. I will talk about other one also give the macrocytic anemia in the next time. Then mean corpuscular volume will be greater than 100 in acquire. When it is genetical problem, congenital sideroblast anemia, serum iron will be high, ferritin will be high, transferrin saturation will be high, total iron binding capacity will be low, and this we expect when someone have high iron in the body. So congenital case, we have macrocytic anemia. So all of these anemic patients show the same symptom, only related to the disease it can show some specific symptom. So what is the diagnosis we do? Like say first person came with history, always in anemic patient history is very important to know he's taking any drugs and all of these. That can give you some kind of narrow down or hints that what's going on in his body. When hemoglobin hematocrit is low, all of this show the same symptoms: syncope, shortness of breath, activity make things worse. We already talked about in part 1. But what we are suspecting, this guy has anemia. This guy came symptom of anemia. We took the history. He has taking alcohol problem. He has taking tuberculosis medicine. This kind of history we already talked about. He could have lead poisoning, zinc poisoning, and we do the corpuscular volume, and after we do the hemoglobin hematocrit value, we found his is low, so we already conclusion that he has anemia. Now we are coming to narrow down our diagnosis, what is causing it. We do them in corpuscular volume, reticulocyte, and we found more corpuscular volume is get lower than 80. Microcytic anemia, microcytic hypochromic anemia, and or in some case like acquire, it could be high. Then history also tell us he is taking the medicine, and we measure the next thing we do always measure the iron level, and iron deficiency anemia, definitely iron is low, and in sideroblast anemia iron will be high, and we measure the ferritin, hazard will be high. We measure the transferrin saturation is high. Total iron binding capacity will be low. Hemoglobin low, we already know that. And this lead poisoning, zinc poisoning also can give the sideroblast anemia, and we measure, we should know that this guy has any lead poisoning or not. So we have to ask the history about his, what kind of job he do, what kind of environment he live, and also zinc poisoning. If we suspect that his bone marrow is in trouble, anytime after rule out all of these and we are suspecting that bone marrow problem is causing the anemia, we have to do the bone marrow biopsy. We took the bone marrow biopsy and we stained with Prussian blue, and we found in erythroid series there is a ring sideroblast. And what is the ring sideroblast? It is in erythroblast series. It has iron in the mitochondria, which is easily visible in perinuclear granule. You take the biopsy, you do the Prussian blue, and you looking for in erythroblast, and you will see them in the iron-laden mitochondria in the perinuclear granule. And most of the sideroblast anemia patient could have basophilic stiffling and could be also seen. And someone have poison inlaid, they can also have basophilic stiffling. So if you take you take the bone marrow, if you take the blood and you are looking it under the microscope, you may see hypochromic or even could be normochromic microcytic anemia. So you already identified this guy has sideroblast anemia. You took the bone marrow and you looked this, and there is a ring sideroblast, and you are thinking, what if someone, you already come to the conclusion that this guy could have sideroblast anemia, and what sideroblast anemia can do to this person. What should be worry for the future of this person? This person has not, percentage is not very high. Few people with the disease of sideroblast anemia can develop myelogenic leukemia. Remember, myelogenous leukemia this person can have. So if this person has history tell that this person has sideroblast anemia due to taking any medicine, try to take off this patient from that medicine. If this person lead is causing the problem, this person have sideroblast anemia, so give this patient chelation as an EDTA, dimercaprol, penicillamine, sacimar, all of this you can give. And if you think this guy have genetics problem is causing his sideroblast anemia, in this case you give him vitamin B6 pyridoxine. Tuberculosis medicine causing it, give him vitamin B6. Alcohol is causing this problem, give pyridoxine. So pyridoxine is one of the important to deal with this guy. And what other thing can give a person to have ring sideroblast? We already talked about sideroblastic anemia, myelodysplastic syndrome, bone marrow problem. The GAM can give, if you look at the biopsy of the bone marrow and you do the Prussian blue and you see the ring sideroblast in the mitochondria. And you can also see the same thing, ring sideroblast, in the pre-leukemic syndrome. and all of them will give the macrocytic anemia, mean corpuscular volume will be greater than 100. So let little bit talk about what is ring sideroblast. Ring sideroblast is when iron accumulates in the mitochondria of red blood cell. We call it ring sideroblast. And when we will see this in the lab test, our history tell us we are thinking about the anemia, we should ask for more about his history, like is he taking any alcohol, is he taking any tuberculosis medicine like isoniazid, and these people even could, you'll see ring sideroblast in the peripheral blood smear. So you can ask yourself why this guy has high level of iron in his serum, because he's not using the iron to produce red blood cell, and iron is accumulated in the mitochondria, which is giving the ring sideroblast, and that's why his iron will be in the serum will be high. And when iron will be high, his ferritin will be high, like any people. And when ferritin is high, it gives us that his iron storage is high in the bone marrow. He has high level of iron, like hemosiderin. If you do the biopsy, we will see the hemosiderin level will be high. And so like all disease except anemia of chronic disease, when iron high, iron storage will be high. Anemia of chronic disease, we will talk about iron storage is high but iron level is low in anemia of chronic disease. What we know about the transferrin? This guy has no problem in producing transferrin, like anemia of chronic disease who have a problem to produce transferrin. So transferrin saturation will be high because he has high serum iron. His total iron binding capacity will be low because he has high saturation of iron in the transferrin, because he has high iron in the serum. So transferrin production is not a problem here, like anemia of chronic disease. So total iron binding capacity will be low, transferrin saturation will be high due to high level of serum iron. So we find out when serum iron will be high except the anemia of chronic disease, transferrin saturation will be high and total iron binding capacity will be low. In iron deficiency anemia, iron is low, transferrin saturation is low, so iron binding capacity, total iron binding capacity will be high. There is no problem in producing transferrin like anemia of chronic disease in iron deficiency anemia. So let's talk about what is sideroblast, what is erythroblast. This also you have to know about how From step 1, you know how the red blood cell produce from the bone marrow in different stages, sideroblast, erythroblast, all of this. Why the isoniazide causing the problem to sideroblast anemia? Because isoniazide antagonize the pyridoxine, and vitamin B6 is pyridoxine, and vitamin B6 you need to produce the phosphoporphyrin for the heme synthesis. Isoniazide cause the problem in heme synthesis because isoniazide antagonize the pyridoxine. So without normal activity of pyridoxine, we have a problem to produce the phosphoporphyrin. So when phosphoporphyrin cannot be produced and iron cannot be bind with it, and we will see microcytic anemia, like say in anemia in a genetic disease, and serum iron will be high. So you have to know why alcohol is causing the problem to have vitamin B6. Alcohol can cause the problem in absorption of vitamin B6. So when a person is alcoholic, his vitamin B6 could be low, that can cause sideroblast anemia, and alcohol itself can suppress the bone marrow. So alcohol can cause someone to have anemia. So as we talked before, when we are going to do the biopsy of the bone marrow, in two cases I talked before. One, you are suspecting a guy has iron deficiency anemia, and same time he has infection going on. Iron deficiency anemia, usually ferritin will be low, but you measure the iron, ferritin, serum ferritin, and it come high. So it's kind of give you confusion. You are suspecting he has iron deficiency anemia, but his ferritin is high. In this case, you can do the bone marrow biopsy to see the hemosiderin level. Ferritin and hemosiderin, same thing. Ferritin, when accumulate, make a granule, we call the hemosiderin. And guy you are suspecting have iron deficiency anemia, ferritin is high, you do the bone marrow biopsy, you see the hemosiderin level is low, that give you hints that this guy have infection going on that is causing his ferritin is high, but actually this person has iron deficiency anemia. So you can treat him by giving him iron. Now this is all about the sideroblast anemia. What is it? That iron is trapped in the mitochondria and give the ring sideroblast. Now let's talk about anemia of chronic disease. Anemia of chronic disease, also we call it anemia of inflammation. In anemia of chronic disease, what is the problem going on here? he could have problem to produce erythropoietin. He could have problem to produce transferrin. So when serum transferrin level will go down, his total iron binding capacity will be go down. And you need the erythropoietin to release the iron from the ferritin. So erythropoietin is low, iron cannot be released from the ferritin. So, or iron also stored in the macrophage, that will be not also released. And so erythropoietin when go down, it cannot stimulate ferritin to release the iron, macrophage to release the iron in anemia of chronic disease. So iron will not be released from the ferritin. So this guy have high storage of the iron, but iron is not releasing. That's why his serum iron will be low, like iron deficiency anemia. The problem will be iron, ferritin will be high, iron is low. So you are thinking the person came with anemia and you are still history, your history is the big thing. You have to know what's going on in his life, and you are thinking now this guy could have anemia of chronic disease, and you already thinking this guy have anemia. You did like all case hemoglobin hematocrit, and it come low. Anytime you suspecting guy is losing the blood through his GI tract, before you do hemoglobin hematocrit, you can just look at it has any blood in his stool or not. And hemoglobin hematocrit come low, you do the mean corpuscular volume and reticulocyte, it come mean corpuscular volume come below 80, reticulocyte count is low, and this guy anemia of chronic disease, you have to also measure, you can measure the erythropoietin. And always after you do the hemoglobin hematocrit, next you do the mean corpuscular volume reticulocyte, next you do the measure the serum iron. Serum iron is low and ferritin, these two. Serum iron is low, ferritin high. That's the main thing. You have to, only the case it happened, ferritin is high, iron is low, anemia of chronic disease, and you have a history about his disease going on, just give you instant to know that this guy has anemia of chronic disease, what's going on. So what history are you looking for? Like say someone has rheumatoid arthritis. This is one kind of inflammation going on, for example, for last 4 years. So it's an inflammatory disease, and because anemia of chronic disease we also call the anemia of inflammation. So rheumatoid arthritis is kind of inflammatory disease, and you already know he has hypochromic microcytic anemia, because when iron go down, this person will develop hypochromic microcytic anemia. If you think rheumatoid arthritis is inflammatory disease, what about the osteoarthritis? Is this the inflammatory disease? No. This rheumatoid arthritis is inflammatory disease. Osteoarthritis is degenerative disease. So osteoarthritis we don't consider as inflammatory disease, so it not give the anemia of chronic disease. It can give the anemia when person has a pain because he has osteoarthritis and he is taking ibuprofen, this kind of medicine, and you are thinking this guy could lose blood because he is taking medicine. In this case, if you measure his iron, it will be low and his ferritin will be low, and you can come to the conclusion because he has osteoarthritis, he is taking ibuprofen, he has losing blood to his GI tract, that's why it is causing him iron deficiency anemia. Iron deficiency anemia can give the hypochromic microcytic anemia. And anemia of chronic disease can also give microcytic anemia or normocytic anemia. Normochromic normocytic anemia. Like say someone has chronic infection, someone have neoplasm, autoimmune disorder, heart disease, acute inflammation going on, diabetics. All this can cause normochromic normocytic anemia. So anemia of chronic disease can give normochromic normocytic anemia, hypochromic microcytic anemia. When this can happen? We already talked about anemia of chronic disease erythropoietin production can go down. When erythropoietin is not producing that much and serum iron is normal, and this guy can develop normochromic normocytic anemia. If this guy have serum iron and both erythropoietin is low, he can have hypochromic microcytic anemia. So two things is working on here. Just decrease erythropoietin, he will develop normocytic normochromic anemia. If this guy have both iron problem and erythropoietin problem, he can have hypochromic microcytic anemia. And iron itself deficiency can give the hypochromic microcytic anemia. And renal disease itself can give the macrocytic anemia. Cancer, autoimmune disease, we already talked about this. This can give normochromic normocytic anemia. When iron deficiency, iron is low, it can give the microcytic hypochromic anemia. So in anemia of chronic disease, why this guy has microcytic anemia? When iron will be enough, but it will be not be able to use it. Like say ferritin cannot release the iron, serum iron will be low, and then bone marrow has low iron, and that can give you microcytic hypochromic anemia. So in anemia of chronic disease, main thing we have to look for utilization of the iron and erythropoietin production. These two are the mechanism to give the anemia of chronic disease. Like the sideroblast anemia, who has a problem in iron, it give the ring sideroblast. In anemia of chronic disease, we don't have this kind of problem. We can utilize the iron, but here the iron is low. In sideroblast anemia, iron is high, serum iron is high. So again, you are thinking someone has anemia, know the hemoglobin hematocrit low, then you know the corpuscular volume and reticulocyte low. I mean, in corpuscular volume below 80 and reticulocyte count is low. Next thing you will measure the serum iron. Serum iron in anemia of chronic disease will be low, and you have to know when you know the serum iron, same time you know the ferritin will be high. Only the case in anemia of chronic disease. So where we store the iron? We store the iron in the spleen, because old red blood cell go to the spleen and macrophage get this iron and is trapped on there, and we don't have enough iron to synthesis hemoglobin, so we develop the iron deficiency anemia. So basically, anemia of chronic disease, we are developing iron deficiency anemia. That's why it gives the macrocytic hypochromic anemia. And when we could have erythropoietin problem. Erythropoietin is produced in the kidney. So any people has problem in the kidney, he can have problem to produce the erythropoietin, and then lack of erythropoietin, he cannot release the iron from the ferritin, so serum iron will be low. And sometimes you have erythropoietin, bone marrow is not responding properly, and that can cause, in anemia of chronic disease, that can cause also anemia of chronic disease. Erythropoietin, but you have erythropoietin but bone marrow is not responding properly, so you can in anemia of chronic disease, so you can have microcytic hypochromic microcytic anemia. Because without proper stimulation of the erythropoietin, red blood cell will be not produced properly. So we talked before about transferrin, total iron binding capacity, ferritin, all of this. So what is the case in anemia of chronic disease? In anemia of chronic disease, total iron binding capacity is low. Why? Because transferrin production is low. Here, just give an example. Someone has any iron deficiency anemia. His transferrin is 10 gram, for example, and iron deficiency anemia, when is 10 gram, anemia of chronic disease, it will be 5 gram. And so his iron, the total iron binding capacity will be low. His iron is low in the serum. But in the iron deficiency anemia, we have serum iron is low, transferrin saturation is low, total iron binding capacity is high. And because he has no problem in production of the transferrin. In anemia of chronic disease, transferrin production is low, so total iron binding capacity will be low. And I will give you put all three: iron deficiency anemia, anemia of chronic disease, and sideroblast anemia. Then we will differentiate in different things, like say ferritin, transferrin, and bone marrow. If you do the bone marrow biopsy, what you will see, what is total iron binding capacity, saturation of the ferritin, saturation of the transferrin. Sorry, we will talk about this. And we already know the clinical presentation of all kind of anemia will also give the same thing, but history is giving you some kind of idea what is actually giving the person is anemia of chronic disease. And what kind of lab test we will do if we suspect person has anemia of chronic disease. So we already know that every case we are suspecting this guy have anemia of chronic disease. We did the hemoglobin hematocrit come low. We do the mean corpuscular volume, reticulocyte. Mean corpuscular volume is below 80, reticulocyte is low. And then we do the iron test, and iron came, this guy is in anemia of chronic disease is low, but the ferritin is normal to increase. This give us pinpoint diagnosis that this guy have anemia of chronic disease. Serum iron is low, ferritin is high, because iron is trapped in the storage as in the form of ferritin or hemosiderin, and we cannot utilize this iron in anemia of chronic disease because he could have problem in production in the erythropoietin, or our erythropoietin is normal but erythropoietin cannot work properly. That can give you anemia of chronic disease. And so what will be the total iron binding capacity? Decrease, because his transferrin is low. And transferrin saturation will be normal to increase. Transferrin saturation, this guy will normal to increase. and his reticulocyte count will be low. We already know that the red cell distribution is normal, only it increases in iron deficiency anemia. Now let me compare the lab test of anemia of chronic disease, iron deficiency anemia, sideroblast anemia. Serum ferritin will be iron will be low in anemia of chronic disease, definitely iron deficiency anemia, and sideroblast anemia serum iron will be high. Transferrin will be normal to low in anemia of chronic disease, and iron it will be high. Sideroblast anemia it could be the normal. And saturation of the transferrin will be low in anemia of chronic disease because he has low iron in the serum. Iron deficiency anemia, transferrin saturation will be low, and ferritin will be normal to high in anemia of chronic disease. Iron deficiency anemia, ferritin is low. Sideroblast anemia, ferritin is high. And bone marrow biopsy, if you do anemia of chronic disease, when ferritin is high, so bone storage in the iron storage in the bone marrow will be high. Iron deficiency anemia, it would be low, and sideroblast anemia, it will be high. And total iron binding capacity is low in anemia of chronic disease, is high in iron deficiency anemia, and low in sideroblast anemia. So in 3 cases we have high storage of the iron in the bone marrow. What is this? This is hemochromatosis. Someone has genetics problem, he is absorbing too much of the iron, his bone marrow will have high storage of the iron. Anemia of chronic disease and sideroblast anemia, in these 3 cases person could have high storage of iron in the bone marrow. So these lab tests can give us hints that what is the causing of the problem. Someone has anemia. So that's why I am going to talk about this, comparing 3 diseases: anemia of chronic disease, iron deficiency anemia, and sideroblast anemia. So after we know the hemoglobin, hematocrit, mid-corpuscular volume, and reticulocyte, our third test is the iron, serum iron, and the ferritin level. So serum iron will be low in iron deficiency anemia, anemia of chronic disease. High will be sideroblast anemia, and we already discussed is why. Transferrin will be low in anemia of chronic disease because we have a problem in production of transferrin, but it will be high in iron deficiency anemia. It could be normal in sideroblast anemia. Saturation of the transferrin will be low in anemia of chronic disease, iron deficiency anemia, and sideroblast anemia, it will be high, because in anemia of chronic disease his transferrin production is low. So he doesn't have enough transferrin to be saturated. Even his serum iron is low. The ferritin is high in anemia of chronic disease because he has a storage of the iron, but he cannot utilize it, so his serum iron will be low in anemia of chronic disease. So ferritin will be high in anemia of chronic disease, ferritin will be low in iron deficiency anemia, and sideroblast anemia has high serum iron that can give automatically he has more ferritin in the serum. Bone marrow biopsy to know storage of the iron. Anemia of chronic disease, it will be high. Iron deficiency anemia, it will be low. Sideroblast anemia, it will be high. And total iron binding capacity will be decreased in anemia of chronic disease because of the transferrin production is low. And iron deficiency anemia, it will be high because transferase is not saturated with the iron, so it can carry more iron. And sideroblast anemia, total iron capacity is low because serum iron is high, so his saturation of the iron in transferrin is high, so he has a low capacity to carry more iron. So after we know that this guy have anemia of chronic disease, how we will going to manage this patient? If we know that, for example, this guy has rheumatoid arthritis and it is inflammatory disease, if we can manage the rheumatoid arthritis by giving medicine, for example, you give etanercept, infliximab, methotrexate, hydroxychloroquine, all of these, and you can suppress his inflammation. It can give when after you suppress his inflammation, you can because of inflammation causing him to have anemia of chronic disease, and he is developing a microcytic anemia or normocytic anemia, and if you manage his inflammation, you can manage his anemic problem. And if we already discussed this, his erythropoietin product could be low. If you measure the erythropoietin it become low, we can think to give this guy erythropoietin. And we already talked about that erythropoietin produced in the kidney, and if this guy has a disease in the kidney, this guy has renal disease, his erythropoietin production could be low. If erythropoietin is low in the problem, most of the case you think to give erythropoietin if you know this guy have a problem in the kidney, and you already identify this guy has a kidney problem, his erythropoietin, his production is low, give him erythropoietin. And usually this is the case, we usually give the erythropoietin, not all the cases. And because someone has rheumatoid arthritis, erythropoietin is little low, we take care of the rheumatoid arthritis, we hope that his erythropoietin production will come to the normal. And if someone has end-stage renal disease and he's not producing enough erythropoietin, and if we give the erythropoietin, the results show that person is responding well and his anemic disease is in under control. So when someone have kidney disease and this is erythropoietin is low, and give him erythropoietin. And as we already talked about this anemia of chronic disease, erythropoietin cannot release the iron from the ferritin, so serum iron will be low. And but most of the case, if we can manage the patient, their inflammation and chronic disease, and person erythropoietin will start producing. But person already has a kidney problem, and when erythropoietin produced in the kidney, probably he's not going to produce good level of erythropoietin. And some people have infection with HIV or hepatitis B, hepatitis C, and this is a kind of chronic disease. This guy can show anemia of chronic disease, and symptom you found this guy thrombocytopenia, it has a platelet count is low. This guy could have thrombocytopenia, and why this guy has thrombocytopenia? This guy, after the infection with HIV or hepatitis B or hepatitis C, this guy can develop idiopathic thrombocytopenic purpura. So he is developing kind of antibody against the platelet that can cause the thrombocytopenia, because his immune system is attacking the platelet. So this is kind of discussion about the anemia of chronic disease. Let me we talk about more about anemia of chronic disease, how it cannot segregate the iron from the bone marrow, which is the storage side of the ferritin. And anemia of chronic disease, ferritin storage iron in the bone marrow increase, or it could be normal. So ferritin could be even increase or normal in anemia of chronic disease, but he has plenty of iron, only he cannot utilize it. His ferritin has iron, but we cannot separate the iron from the ferritin. That can cause him like iron deficiency anemia type problem, and he can have microcytic hypochromic anemia. So this guy has no problem to store his iron in the bone marrow, but iron cannot be segregated from the bone marrow due to bone marrow cannot be stimulated enough with the erythropoietin. So it cannot use the iron, store the iron in the bone marrow, but it cannot use it. And in this case, his storage of iron in the bone marrow will increase, so therefore his ferritin will be increased. His anemia of chronic disease, he has a decreased serum transferrin because he cannot produce it. So his total iron binding, that can lead to his total iron binding capacity will be decreased. In normal person, iron would be in the bone marrow. When iron will be need, bone marrow will release the iron, and then serum iron is low in normal person. Bone marrow will release the iron, and then serum iron will come to the normal. So again, iron is stored in the bone marrow but cannot segregate from the bone marrow, let's say from the ferritin. So serum iron is low due to the macrophage will keep the iron. So when iron is low, red blood cell production will decrease. It can cause the decreased production of the reticulocyte. Person will develop microcytic hypochromic anemia. So as we know that before, transferrin, ferritin, all are this kind of protein, and ferritin cause the iron to be stored in the body. In iron deficiency anemia, serum ferritin level go down because iron storage is low. So serum ferritin, as we talked with before, again to remind, serum ferritin will go up in 3 cases. What is this? Anemia of chronic disease, sideroblast anemia, or hemochromatosis. And when serum iron will go high, ferritin level usually go high. Like say hemochromatosis, we have genetics problem, we are absorbing too much iron, and our ferritin, we are storing too much of iron, our ferritin will be go high. In sideroblast anemia, we have high level of serum iron that can cause serum ferritin will be high. So anemia of chronic disease, we have a defect in utilization of the storage iron. Let's talk about little bit about the person has diabetes, for example, and he developed end-stage renal disease. After he developed end-stage renal disease, he developed anemia, and we know that this is anemia of chronic disease. He has a long history of the kidney problem, and he has a problem in kidney failure, and he's not producing enough erythropoietin, and when only erythropoietin problem, he could have problem in normocytic anemia, and at the same time he has iron problem. He can have microcytic hypochromic anemia. And we told before to give erythropoietin to this guy, and before we go erythropoietin, give this guy erythropoietin, what other thing we have to look, because if we give the erythropoietin, this guy is just starting producing the red blood cell. But if this guy has iron deficiency, for example, and we give him erythropoietin, he's producing red blood cell, and he's going to develop iron deficiency. And so before we give the erythropoietin, we have to look at this iron level, and because if you give the erythropoietin, he will start producing the red blood cell, and his iron could go down, and he will come up with develop the microcytic anemia due to the iron deficiency. So before give the erythropoietin, we have to know his storage of the iron body level, and after we know his iron level, then If it be low, we will give him iron, and then after that we will give him erythropoietin. So talk this again. Someone have renal disease, he has erythropoietin problem, and you decide to give him erythropoietin. And before you give the erythropoietin, you have to make sure about his storage of the iron. If it be normal, we can give him erythropoietin, and same time we give him iron, because he can he's producing too much of the red blood cell, and he can end up with developing iron deficiency anemia. Then he can develop again microcytic anemia. And again, know the iron, then give erythropoietin. And when give the erythropoietin, give him iron. If this person is in dialysis, first give iron, then give erythropoietin. And if this person is not in dialysis, and we can just give him iron supplement. And in justice renal disease, we know the total iron binding capacity is serum. In justice renal disease, we consider is anemia of chronic disease. His total iron binding capacity and the serum iron will be low. So again, before you give the erythropoietin, you have to know about his serum iron level and the iron storage. So we have to know the serum iron, and we also know the ferritin. If ferritin is low, we have to give him iron. And is ferritin, so before we give erythropoietin, if ferritin is low, we give him iron first, then give the erythropoietin. If the ferritin is normal, we can give him erythropoietin. Same time we have to give him iron, because this guy, erythropoietin will start producing a lot of red blood cell, and he will end up with iron deficiency anemia, and that's to prevent it, we have to keep this guy on iron. Okay, this is the end of the topics about the sideroblast anemia and anemia of chronic disease. This will be the part 4 of the hematology. Next we are talking about the thalassemia, beta thalassemia minor, beta thalassemia major, and yeah, that will be the part 5. So we will discuss about all of this again in the part 5. Thank you to listen the lecture about the hematology and about the sideroblast anemia and anemia of chronic disease.